Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to the Gonioscopy series. Today we are studying the important gonioscopic features in an angle closure disease. So without any delay, let's get started. A very simple approach to gonioscopy is that whenever you do a gonioscopy, if you see the scleral spur, that indicates that it's an open angle. And if you do not see a scleral spur, maybe you are seeing only the anterior trabecular meshwork or the posterior trabecular meshwork, then what do? We will do an indentation gonioscopy, and then we will establish if the closure is appositional or synechial. In apposition, there is just an iridotrabecular contact, but in synechial, there is synechiae which is present between the iris and the trabecular meshwork, which cannot be broken so easily, and therefore the angle will not open even on indentation gonioscopy. So very simply to tell you, scleral spur, whenever it is visible, the angle is wide open, okay, and whenever the posterior trabecular meshwork is seen, then also the angle is actually open. If you see the anterior trabecular meshwork, which is not the functioning part of the trabecular meshwork, which is the non-pigmented part of the trabecular meshwork, you do an indentation gonioscopy, and based on the finding of the indentation gonioscopy, you tell whether it is an appositional angle closure or a synechial angle closure. So that is just a summary of the previous video that I have told you on the indentation gonioscopy. Now, what is meant by the term occludable angle? So there's a lot of controversy and there's a lot of confusion about the angle closure. So I will just clarify one by one. So what is meant by this occludable angle? So occludable angle means that if the pigmented trabecular meshwork, that means the posterior trabecular meshwork, is not visible in at least 3 quadrants in primary position without any manipulation, the angle is labeled as occludable. So if you see this to be the angle, we can divide it into 4 quadrants. Each quadrant is about 90 degrees, right? So if you do not see the posterior trabecular meshwork in at least 3 quadrants, that means 90, 180 and 270. That means a total of 270 degrees you are not seeing the posterior trabecular meshwork, and you are able to see posterior trabecular meshwork only in 1 quadrant, okay, then such an angle is at risk of closure, and such an angle is at risk of progressing to angle closure glaucoma, and such angles, high risk angles, are called the occludable angles. Now this 270 degree, there's a controversy between 270 and 180 degrees. They say that in Asian eyes, which are smaller eyes, which are at more risk of progressing to angle closure, the cutoff is taken to be 180 degrees, whereas in other non-Asians, this value is taken to be 270 degrees. That means the posterior trabecular meshwork or pigmented trabecular meshwork is not visible in about 270 degrees in non-Asian eyes, and not visible in 180 degrees of Asian's eye without any manipulation. So that is called an occludable angle. So if you do not know what is manipulation, check the video on the Goldman's gonioscopy with manipulation gonioscopy. So what happens in this occludable angle? If the angle actually gets closed and if for a considerable amount of time, and then the filtration is compromised, what will happen? The pressure is going to rise. So in that case, the patient is going to come to you with acute angle closure. Okay, in acute angle closure, the signs and symptoms are quite obvious, and the pressure also will be high. So because of the high pressure, what happens is there will be this corneal edema. So cornea will not be clear. There will be cloudiness of the cornea, and that is basically microcystic corneal edema. Okay, so if you put your slit lamps, focus it on the cornea, you will see very small cysts which are very small, and therefore it is called the microcystic corneal edema. Okay, along with that, you will have this redness around the cornea, which is called circumciliary congestion or circumcorneal congestion. Okay, and along with that, you will have this fixed mid-dilated pupil. So this is very common presentation of acute angle closure glaucoma, and along with that, patient comes with headache, with nausea and vomiting. Okay, and in a case of acute angle closure glaucoma, because there is corneal edema, usually the gonioscopy is not advised. So you put the patient on anti-glaucoma medications, okay, you bring down their pressures, and then you go for the gonioscopy, and in the gonioscopy you will see that the angle structures are not visible. How do you know? In this diagram, if you see, this is the corneal wedge, and you can see this is the first line and this is the second line of the corneal corneal wedge, but they are not meeting at any location which is visible to us. So as we all know that the two lines of the corneal wedge will meet at the Schwalbe's line, and if you are not able to see that junction of the two corneal wedges of the two corneal lines of the corneal wedge, that means that we are not able to see the Schwalbe's line in this picture, and an angle where we cannot see even the Schwalbe's line, that is definitely a closed angle. So I hope that is clear. Next is, so what are the features that I told you? Patient will have circumcorneal congestion, corneal edema, which is microcystic corneal edema because of the raised IOP, and in this raised IOP it is advisable that you do not do any indentation gonioscopy, and the angle, if at all you do a gonioscopy later on when the corneal edema subsides, the angle will be shallow or narrow. And another feature is that the other eye will also have, if suppose this is the eye which presents with acute angle closure, okay, and this is the other normal eye. When you do gonioscopy on the other eye, you will see that there is narrowing of the angle present in the other eye as well. So whenever a patient comes to you with acute angle closure glaucoma in one eye, it is always advisable that you do a gonioscopy in the other eye to look for clues from the other eye as to this eye also might be having narrow angles. So what are the signs that you see? What are the very common signs into the eye that you see are iris whirling, atrophy of the iris, and glaucom flecken. So all this is happening because of that sudden increased pressure inside the eye, because of which, say, the iris is going to lose its pigment and there will be atrophic patches. The iris is going to lose its normal radial architecture. Okay, the iris fibers are arranged like this. So this is going to be lost. So what happens is that instead of being radially oriented, now some of the fibers which have suffered ischemia because of that raised pressure, what will happen? They will take a whirled kind of appearance. So instead of this radial thing, few of the fibers will be like this in a circular arrangement, and this is called iris whirling. Okay, now because of the increased pressure, again there can also be ischemia to a very important part of the lens, and that is the anterior capsule of the lens, which is metabolically active. So when this anterior capsule suffers from ischemic damage, there will be necrosis of the anterior lens capsule epithelium, leading to opacity development, and that is called glaucom flecken. So in this picture, first picture, you can see that here these are the atrophic patches which are present onto the iris. Okay, and this is a lens which has developed cataract, and then here you can see the iris is radial here, and from here, if you notice carefully, this is going somewhat in a circular direction. If you notice from this area to this area, this is called iris whirling. Now similarly here you can see this is the anterior capsule, and you can see opacification developing from the anterior capsule, and that is called glaucom flecken, a very important sign of previous acute angle closure attacks. Now the patient can come as acute presentation, or they can also come as intermittent angle closure. Now intermittent angle closure patients will give history of intermittent headaches. So what happens is the angle closure will happen and it will subside on its own. So they will have intermittent history of headaches. Along with the headaches, they will have blurring of vision and development of colored halos. The thing is that they will all resolve on their own, but it is very important to diagnose them, because these patients can also gradually progress to angle closure chronically. Okay, so gradually they can develop synechiae in their angle, and that will lead to chronic angle closure. So what is chronic angle closure? As I told you, in chronic angle closure, basically the synechial formation will occur like this. You can see this goniosynechiae. So here is a pigmented trabecular meshwork, and you can see this iris coming and attaching over to the trabecular meshwork. So because of this thick attachment, the trabecular meshwork which is present behind this iris will not be functioning, right? So because of that, the pressure is going to rise, and this is called chronic angle closure, a difficult condition to treat. So what causes chronic angle closure? Now there are different mechanisms by which chronic angle closure will occur. So basically what happens is, because of some reason, either of the three reasons. Okay, so let me tell you. First is pupillary block, second is plateau iris configuration, and third is lens intumescence. So pupillary block, plateau iris configuration, and lens intumescence. So any of these three things will lead to chronic iridotrabecular contact. That means if this is the cornea and this is the iris over here and this is the pupil, so what will happen chronically because of these three mechanisms, what will happen, the iris will be coming in close contact to the angle, that means here the trabecular meshwork. Because of these three reasons, there will be chronic contact between the iris and the trabecular meshwork, and that is called chronic iridotrabecular contact. Now when they are existing in close proximity to each other for such a long period of time, what happens is that they will develop peripheral anterior synechiae. That means the connection will develop between the iris and the trabecular meshwork, and that abnormal connection is called synechiae formation. And as I told you, the synechiae will block the flow of aqueous, and when the flow of aqueous will be blocked, what will happen? The pressure is going to rise. So that's the pathophysiology of chronic angle closure, and the main mechanisms are pupillary block, plateau iris configuration, and lens intumescence. Now let me tell you what is meant by pupillary block first. So the pupillary block is also called the relative pupillary block. Now there are a lot of pupillary blocks which I will be telling you in another video. Okay. So what is meant by this relative pupillary block? Now we know that usually what happens is that we have our ciliary body here which is going to secrete the aqueous in the posterior chamber. From the posterior chamber, that is the chamber behind the iris, the aqueous is going to flow through the pupillary area and come into the anterior chamber and then go into the angle and get drained outside the eye. Okay. However, what might happen sometimes is that there will be abnormal connection which will develop between the iris and the lens. Now because of this abnormal connection between the iris and the lens, the aqueous which is trapped in the posterior chamber will not be able to flow anteriorly into the anterior chamber. So what happens? The aqueous is getting built up in this posterior chamber, and because of that the iris is getting pushed forward, taking a convex configuration, and that convex configuration is called the iris bombae, and this condition is called the relative pupillary block. So what is happening? The aqueous is getting accumulated in the posterior chamber, pushing the iris anteriorly, because of which you can see in this picture the iris is more of a elevated form, okay, a convex shape, and this is called the iris bombae. Because of this iris bombae, basically the peripherally what is happening, because of the convex configuration, the iris is coming in contact with the cornea and there is iridotrabecular contact, because of which again the pressure is going to rise, leading to chronic angle closure. So that is the first mechanism, relative pupillary block and iris bombae. Next, coming to the plateau iris configuration and syndrome. Before that, you should know what is a plateau. So a plateau is basically a flat area like this. So it's an elevated and then it's a continuous flat landscape is called a plateau. Okay, like this, as I've shown you in the picture. So the iris also takes a flat configuration and a flat approach to the angle. So what I mean to say is, if this is the cornea, okay, and here you have the Schwall baseline in the angle, trabecular meshwork, scleral spur, the ciliary body band roughly. Okay, this is how the angle structures are present, and then you have the iris. Now what happens is the iris is going to the pupil. The iris is going to actually be present in the plane of the Schwall baseline, flat like this. Okay, the iris appears to be in the plane with the Schwall baseline for a period of time, and in this point what happens is that as it is approaching the angle, the iris is going to then sharply drop downward and insert here like this. Okay, so this is how the plateau iris is like. Normally it will be like this and then gets inserted on the scleral spur. So definitely it is open, definitely it is not really a closed angle. You do have some space for the aqueous to flow. However, what happens is that here in the iris we know that there's a peripherally on the iris, there is a roll of the iris which is present. Okay, so there will be a peripheral roll of the iris which is present like this. And why do we have this elevated roll? Because of the presence of the ciliary body. So we know that here we'll have the ciliary body. So some of the ciliary body processes will be anteriorly rotated, and because of the anterior rotation they are going to produce this roll over the peripheral part of the iris, leading to the formation of the plateau iris. So let me show you in this picture. So here initially the iris is flat at the level of the scleral spur, then there is a prominent roll Okay, this prominent role is causing that contact, but here it is dipping down and inserting into the scleral spur. So you do have a space which is very narrow, however, but here there is a roll which you see in the periphery. This is the roll. Why do you see that roll? Because the ciliary body processes are anteriorly located and they are causing pressure on the iris and producing that peripheral roll of the iris. So this is your plateau iris configuration. So I hope that is clear to you. So plateau iris configuration is nothing but it is an anteriorly positioned ciliary processes that will critically narrow the anterior chamber recess by pushing the peripheral iris forward, and it is seen in case of young adults. Now at this point, a very important academical question is, what is plateau iris configuration versus what is meant by plateau iris syndrome? Now the three mechanisms that I told you, whether it is relative pupillary block, whether it is plateau iris, okay, or whether it is intubescent, they can all occur together or in combination with one another. It is not that you have just a plateau iris and you cannot have a relative pupillary block along with that. Okay, so they all can coexist or they can all occur in various combination. So a patient who presents with plateau iris configuration, okay, it is advisable that you do a peripheral iridotomy. A peripheral iridotomy is a treatment specifically for relative pupillary block in which we have iris bombae, and when we open up this opening, when we create an opening in the peripheral iris, what happens is that the aqueous which was accumulated in the posterior chamber will now flow through that opening into the anterior chamber, and the iris will now become flattened, relieving that relative pupillary block. Now, it is advisable that even in plateau iris configuration, you actually do a peripheral iridotomy and relieve that relative pupillary block component of the patient. Okay, now after that also, if the patient is having a persistent occludable angle despite a patent iridotomy, even then if the angle is not become flattened, then the patient is said to have a plateau iris syndrome. So what is important is that in plateau iris syndrome, there must be a patent iridotomy. Only after doing a patent iridotomy of a patient with plateau iris configuration, you can label the patient as plateau iris syndrome. Okay, yeah. Now in this picture, you can see that I have shown you that there are two arrows. These two arrows indicate that the iris is actually flatter here, and here it is at the raised level because of the anteriorly positioned ciliary body processes behind that peripheral roll of the iris. So that is very important. And this is actually called a double hump sign or a sine wave pattern. And this is seen typically in the indentation gonioscopy. When you put indentation, the central part gets deepened when the periphery is still shallow because of the anteriorly positioned ciliary body processes. Similarly, you can see here, okay, so this is quite a narrow entry. You can see this, you can see the corneal wedge, but you cannot see them joining together, okay, and then you can see this roll like this, and then again you can see a roll like this. This is called double hump sign, also called the sine wave pattern seen in indentation gonioscopy. Now there's another mechanism which can cause which can actually cause the angle closure is aqueous misdirection. Okay, very similar to if you understand plateau iris, it is easier to understand aqueous misdirection. So in the plateau iris, the ciliary body processes were basically anteriorly positioned. But what if they are more posteriorly positioned than their normal location? What will happen? The aqueous will actually grow and flow into the vitreous and get accumulated in the vitreous and behind the vitreous. So what happens? The vitreous will be pushed forward, and this vitreous is going to push the lens forward, leading to shallowing and collapsing of the anterior chamber recess. Okay, so this is called aqueous misdirection or ciliary block glaucoma, very common after various kind of surgery. So in the ciliary block glaucoma, what happens is, as you can see, both the central AC depth and the peripheral AC depth will become shallow. So that is very important. In aqueous misdirection, both the central AC and the peripheral AC depth will be narrow. Okay, so this is in difference with the relative pupillary block. So in the first picture, if you see, this is the relative pupillary block with the iris bombae formation. Here the central part of the aqueous, the anterior chamber will be deep, but the periphery will be actually shallow because of the configuration of the iris, which was like this. Okay, iris bombae. However, here the entire iris is actually pushed forward. So the central is deep, shallow, and even the periphery is also shallow. The entire AC is actually collapsed. So this is the aqueous misdirection syndrome. Now, all that was clinically about the angle closure disease. However, to actually get away with so much confusion in the angle closure and its nomenclature, occludable, non-occludable and stuff, the International Society of Ophthalmic Epidemiology classification was given, and it classified the angle closure into three types: primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. So you can classify the patients basically into these three types according to the International Society of Ophthalmic Epidemiology classification. So the first is, what is meant by this primary angle closure suspect? Now, what I told you about the occludable angles, it's the same. So appositional contact or occludable angle between the peripheral iris and the posterior trabecular meshwork in such a way that in 180 to 270 degrees of the posterior trabecular meshwork is not visible in the primary position without any manipulation or indentation. That means you can see posterior trabecular meshwork only in about 90 degrees. Okay, you are not able to see it in 180 to 270 degrees quadrant. So if you can see at least about 3 quadrants you are not seeing the posterior trabecular meshwork, then that is called the primary angle closure suspect. And in that, another thing which is important is the pressure should be normal. There should be no peripheral anterior synechiae and no disc or visual field changes. So no disc changes, no visual field changes, no synechiae, no elevated IOP, just occludable angle in 180 to 270 degrees. Why am I saying this is because in Asians it is taken 180 and in non-Asians it is taken 270. So if you can see this gonioscopic picture, none of the angles, the structures are seen. Almost, if you consider this is about 180 degree quadrant, so you can see, okay, so this will be, if you divide, this is 90, this is 90, so total 180 degrees you cannot see. And in this patient the pressure is normal, the visual fields are normal, optic disc is normal, there are no synechiae which we can see, and therefore this is a case of primary angle closure suspect. The second is primary angle closure. So what is primary angle closure? Primary angle closure is that in this, it is primary angle closure suspect. That means what we told you in primary angle closure suspect. Along with that, you will see certain signs of angle closure. That means IOP will be raised, or you will see some physical sign. That means either peripheral anterior synechiae or even the presence of glaucom flecken. Okay, so all these things, or you can see an iris whirling. So some signs which tell you that previously angle closure took place. Okay, so that is called a peripheral, that's called a primary angle closure. Okay, that means primary angle closure suspect plus either the IOP is raised or some signs are present, synechiae or glaucom flecken or iris whirling. In this also, the disc is normal, the visual fields are normal. So in this picture you can see there are goniosynechiae which are present, okay, and along with that either the pressure is raised and you can see the other structures are not visible. So this is just a this is not a closed angle as such. I have just taken it to show you the goniosynechiae because in this case you can actually see the structure. So this is not really a closed angle, but I have shown you this picture to tell you what is meant by a goniosynechiae. So if this were to be an closed angle along with goniosynechiae formation, then you will label it as primary angle closure. Next, you have primary angle closure glaucoma. So in primary angle closure glaucoma, you will have all the features of primary angle closure. That means you have occludability. Along with that, you have raised IOP or some sign of previous angle closure. Along with that, optic disc and visual field will also be affected. So that will label the patient as having primary angle closure glaucoma. So if you can see this picture here, none of the angle structures are actually seen. Some synechiae are seen, and you can see the disc. Okay, disc is showing this. You can see the RNFL defect here, and then you also have a visual field change. So what do you actually look for in the angle in angle closure? You look for the width, you look for the structures, you look for evidence of previous closure attack. That will be glaucom flecken, sphincter atrophy, increased pigmentation or decreased pigmentation, pattern of pigmentation you see for synechiae formation, whether it is Gonioscopy or anterior synechiae. Specifically, it is a peripheral anterior synechiae that you see in case of an angle closure. Okay, Gonioscopy are limited in might be seen in inflammatory glaucomas, and usually they will be an open angle because they have not reached up to the cornea usually. Symmetry of gonioscopic findings between the two eyes is very important, because sometimes you might have an intumescent cataract, and that because of the intumescent and increased diameter might be pushing the iris forward and leading to shallowing of the ACs. So when you have this narrow angle, okay, in one eye, then maybe the pathology is the intumescence of the lens. Okay, then because in the primary conditions, usually bilaterally there will be narrow angles. Then you have to look for the pathologies that might close the angles, like neovascularization of the angle. So these are the pictures. This is the lens intumescence, intumescent lens. This might actually close the angle. Then synechiae formation. Here you can see this is a narrow entry. There is no Schwalbe's line which is seen. Similarly here, you can see this pigmentation which is present, okay, and the iris is also not at the same level, because here you can see some amount of synechiae formation. And this picture again is telling you about the Gonioscopy, okay, but here Gonioscopy is seen, and you can see some deposition of the pigments also here. Okay, then in this picture, what is more important, which I wanted to see, is the presence of neovascularization. Okay, in this pictures, neovascularization, also what happens is that sometimes you will see neovascularization on the iris, which is definitely a sign that neovascularization might be present in the angle as well. So neovascularization is associated with fibrosis, and when it leads to fibrosis, what happens is that the angle, because the fibrosis will contract, and that will cause the closure of the angle. It will pull the iris forward towards the cornea, and the angle